Hello, everybody, and welcome back to the next episode of the Dental Implant Podcast. So, I'm very happy to have a friend and colleague back again, Bill Schaefer. Bill, I think this is the third time you're joining me, isn't it? So you've been on
second or third, yeah.
Second or third, yeah. So, welcome back, and thank you for joining me on an evening.
It's a pleasure.
And I'm cognizant of the very fact that it's now dark outside, whereas normally, over the summer we'd have like another hour and a half, 2 hours worth of sunshine. So, we're in that time of the year again. So, folks, the reason why I have asked Bill to come on today is he put a post on the ADI group a few days ago, and it's something that I agreed with, and I do feel that this episode may not sit 100% comfortably with everybody, but I also believe it's a very important topic as well. And I will disclose as well that at certain points of my career I have been guilty of this, and I will explain those as we're going along as well. But I think what we want to do is talk about training pathways, and not so much the theory side, because there's a number of different options which are available there, but more so the hands-on element and the mentoring side. And Bill, if you wouldn't mind expanding kind of what you were talking about with regards to our medical colleagues when they do their surgical training, and then if you could go into your surgical training, and then we'll kind of like see where this discussion goes organically from there. But effectively, what we are seeing, and I'm seeing a lot of this as well, is a lot of people they want the bare minimum training and to start to almost get on with it as quickly as what they possibly can. And they are landing themselves in hot water because you and I are seeing cases where we're having to fix it. And ultimately, it's not fair on the patient either. So, Bill, if you wouldn't mind just giving me your thoughts, and again, just introduce yourself to those who may have, for those who may have forgotten about yourself, because I think it's been about a year and a half since you last been on.
So my name's Bill Schaefer. I'm a dentist, a medical doctor, a medically qualified surgeon, a specialist oral surgeon. For the last 20-something years, I've been doing nothing but placing implants. I've been placing implants for 28 years now. Well, this is my 28th year. But I've been doing nothing but place implants for more than 20 years. And when I started doing implant surgery, I was hugely experienced in oral surgery. I had wanted to pursue a career in maxillofacial surgery. And so I was very comfortable fixing broken mandibles, broken zygomas, broken maxillas, orbital floor fractures. I've taken out saliva glands. I've done a load of osteotomies and a massive amount of dental alveolar work. So from the surgical side, I was very experienced in oral surgery. When I started doing implants, I knew nothing about implants. And I was only doing the surgical side of implants. I wasn't doing the restorative side. I was a peripatetic surgeon going into dental practices where they restored. But even with all the experience that I had had, I realized how little I knew about implants. Now, 28 years on, I can look back and see how many things I've got wrong, how many career-ending disasters I have managed to avoid by a whisker, by luck. And I've reached a point where I don't have a huge amount to prove in implants, but I'm at the stage where I can talk a lot about my failures and my complications and my problems. And that's pretty much all I lecture about now, my screw-ups. And I look at the difference between the hospital training that you get to be a surgeon, whether it's a maxillofacial surgeon, an orthopedic surgeon, an ENT surgeon, doesn't matter, and what happens when a dentist decides they want to do implants. And it's terrifying, the lack of help, that we have as dentists. And let's face it, we wing it. I winged it for much of my career. I have spent, I couldn't tell you how many tens of thousands of pounds going on courses, like ridiculous amount, way over £100,000. So I've invested a lot in my training, and I still realize how often I have winged it, been doing things without really knowing what I'm doing. And it doesn't pick anything you like, whether it's grafting, guided surgery, soft tissue, it doesn't matter. Just, I have been doing a lot of things in my career where I've been kind of feeling my way. Now, that's not how it should be done. It's not how it's done in a hospital surgical field. Now, whether it's placing implants or whether it's, doing hip replacements, they both have an academic, cerebral learning knowledge type part, but they have a huge practical element to them. And in hospitals, you will be doing that partly on models. You'll be watching your consultants doing a ridiculous number where you are assisting them. And then they will assist you whilst you do them under their direct supervision. They do years of this. They audit everything. Absolutely everything goes in a logbook, which is regularly interrogated. The outcomes are looked at. How often does this happen with implant people? You and I know, Pav, from speaking to people, most people have no idea how many implants they even place, let alone what their integration rate. And then when you start talking about success rates, they have no idea what success means. I think that when I started 28 years ago, we were in a much less litigious environment. And I think that things are very different now. And again, I look back at how close I have come to career-ending disasters. And with just some help, some support, some advice, some encouragement, some hints and tips, sometimes really simple things, that can be avoided. If we don't learn from each other's mistakes, we are doomed to repeat them. And I really fear that there are lots of courses out there teaching knowledge. There are lots of online resources teaching knowledge. YouTube is brilliant, but that's not the same as doing it yourself, and doing it yourself with someone experienced giving you help and guidance.
Yes. I agree wholeheartedly with everything that you've said there. And I think at this point, it would probably be good to give those listening a little bit of background, how I started. So I actually avoided implants for several years after graduating because I did not like surgery. Now, considering now that everything that I do, like yourself, Bill, is everything around dental implants, that goes to show that it is a learned skill.
Yes.
And there are two aspects of this, as you quite rightly said. We have the theoretical aspect, and then we have the hands-on aspect as well. So when I originally was trained, the gentleman who trained me, very, very, very good surgeon, used to do a lot of all-on-fours. And for me to learn more, I used to go and assist him, and he taught me through the case. And as with any experienced surgeon, he made it look very easy. So, Bill, this was in my first year. So I was still in the middle of undertaking the theoretical training. And I came across a patient who needed to have an all-on-4 in both arches. And she had plenty of bone for it, but she could not afford the fees. So I said to her that I will do this at cost for you. And I will do it at cost. And you're going to save tens of thousands of pounds, But I said to her, I want for you to understand that I've assisted with this several times. I've got the theoretical knowledge, but I've not actually executed this before. And she was quite happy with that. And I did the case, upper and lower all on 4, possibly one of the most stressful things I've ever done.
Yep.
Because I think I'd placed about 10 implants solo by myself before I decided to do this.
What?
And on reflection, at the time, I thought, I can do this, there's plenty of bone. But on reflection, having the knowledge and experience that I have now, it was a stupid thing to do.
Yes.
And 2 of the implants failed. And here's the thing, Bill, I didn't know how to fix the case.
Yes.
So I actually had to send it out at that point. And I sent it over to a friend of mine. And a friend of mine said, yeah, Pav, more than happy to help you. But he was charging full fees for it, which I then had to cover.
Yes.
Even though this patient understood going in, she was only paying £5,000 for a dual arch. I ended up having to pay it out of my pocket because of a mistake that I'd made. Now, had I done a case with a mentor, I'm sure that my mentor would have started by, letting me raise a flap, maybe starting the osteotomies, or he did the pilot burr and I extended the osteotomy slightly. But I went in gung-ho and I made a mistake. And I've made several mistakes like that throughout my career. What I found as well is earlier on in my career, I really pushed pedal to the metal, and it's still something that I enjoy doing, but I love the theory side of it as well. And I found that very quickly, I was learning more and more theory. This was at the time I still owned my own practice, Bill, which was a failing practice. This practice eventually made me go under. And there was an element of ego attached to it. And I think this ego is two-pronged. And I'm saying this just trying to be open with everybody who's listening, okay? I think there's an element of human nature. We like to think, oh, we've studied this, we can do it. And if Joe Bloggs down the road can do it, I can do it. If Bill can do it, I can do it. If Pav can do it, I can do it. There's an element of human ego that comes to it as well. But I think the other thing, when we start to learn these things and we start to put them on our websites, what is it we put on our websites? We say that we're capable of doing this. We don't turn around and say, oh, I haven't done very many of these. The guy down the road is going to give you a better result. And I think there's an element of, if we say our own marketing message over and over again enough, we almost start to believe it. And you almost have this veil of delusion that comes in front of us, okay? And it can be dangerous. And I think as a minimum, what we should have is a group of peers with people of different levels of experience to keep us grounded and turn around and say that, yeah, look, we like the idea of this. Maybe go out for dinner once every 3 months and say, you know what, this case kicked my ass. Can you guys see something that I missed at the time? And even to the point where I had finished my MClin Dent in implantology. So technically I had all of the theory and I was doing full arch cases, which caused me a lot of stress. And it wasn't until I went into a clinic where I was exposed to complex surgery day in and day out for a long, long time. That's when my skills really grew, because I had a lot of mentoring then. So I had this is exactly what we're talking about. I had a lot of the theory, but the mentoring side was lagging behind it. And then the clinical side, it caught up eventually. And I would say that still I'm now very conscious of the fact that there are certain things that I'm very comfortable with, and other things that I need to be more cautious with, and other things that I will still do with a colleague in the room, so that if I get stuck, they can take over. And I think that's the way that we should be looking at things, and we should be striving more towards that. So that's kind of like my background and where I'm sat with everything.
I would just want to say that my intention is not to put barriers to people starting implants. It's certainly not, as someone suggested on the ADI, being protectionist and wanting to stop people being competition for me. I'm not worried about that. I have harmed a lot of patients in 28 years. I've done some amazing stuff, but I've harmed patients, and I've harmed them because I didn't know what I was doing, despite all the experience over the years that I've gained. And it's a really, really horrible feeling when you harm a patient. And I don't want other people to feel that way, and all I needed was someone just to say, maybe that's not the case to start with, or maybe that's not the patient to do this case on. I look back what you were saying when you're, when you're young and dumb and you're starting out and you think you are the bee's knees, you think you are the god of implantology, and you push things, you push to see how far you can do stuff. How big a crestal sinus lift can I do? How little bone do I need? Can I do this immediately? Can I immediately load it as well? And what about doing it with 2 implants and 3 implants? You just push things. And I've done some cases that have been successful. And again, this is something I now lecture about. Cases that have been successful that I have in the past shown as, look how great I am. And now I show them as, I wouldn't do this case again, because the distance between success and absolute disaster is way too small. And that's not because I'm getting old and timid. It's because I've seen how often I have screwed up in the past. And I can be open and honest about it without ignoring it.
Yeah, one of the ways that I explain this is, let's say you and I were to go to Silverstone and we were told, here's an F1 car, get it around the lap as fast as what you possibly can. Are we going to make a better success of it going it alone? Or would it be better with a co-pilot with Lewis Hamilton in the cockpit with you? That's effectively what it is. To address the thing that you said about protectionism, Bill, I agree with you. That's not the case. And it can be very easy for us to say, because we have the volume of patients coming in. But the whole point is we have the volume of patients coming in. There is no lack of business.
Oh,
okay. Between you and I, we can't place every single implant that wants to be placed within the UK.
There is enough work for everybody out there.
No, absolutely. That there is more than enough business for everybody. And that said, we are well behind the continent in compared to numbers. So actually, the business out there is even larger than what it is. So there's plenty of business. It's not a matter of protectionism. It's a matter of keeping the patients safe, bringing optimal outcomes for the patients, and for
keeping
those who want to
safe.
Keep them safe as well, and actually accelerate their career, Bill. When I'm mentoring people now, I teach them things that I only figured out a year ago.
I wish. This is what Ishvan Urban says. He says, I wish I could meet myself 25 years ago and tell that person what I know now.
Yeah.
And with mentoring, it can be really simple stuff. There was a chap who posted on my post on the ADI who was saying that he just can't find cases to start doing implants, having done an expensive course. And I said, all you may need is just to run these cases by someone more experienced who can say, that's not one to start with, but that's a great one, and so's that one. And, present the cases like you would in your course. So do it properly, have photos, have x-rays, maybe have models. Show that you've worked the case up sensibly. And then the experienced mentor is going to say, that's a great one for you to do. And then the mentor can say, how are you going to approach it? Right? And that's all you need. Just someone to say, yeah, that's a great one. Off you go.
Yeah.
Right? We have a lot of surgeons in our centre, and whenever they want to do their first full arch, we make them present the case to the other owner, Guy Barwell, and myself. And all the while through, we're going, what happens if this? What happens if you want to put the implant there, you take the tooth out and the bone comes out attached to the root? What happens if you put the implant in and there's no torque? What happens if this? What happens if that? What happens if? And all the while through, and we very quickly get an idea of if they are serious about it. Are they presenting the case formally to us, or are they just wanting a tick? And have they thought about what to do if and when things go wrong? And then we'll let them do it, and we'll be in the room, but not assisting them unless they need us. But and those people who work with us, they're already incredibly experienced, many hundreds of implants. And even then we are saying, look, this is another stage up. You're going to encounter difficulties, like the case I was talking to you about Friday, where he just bled, and I abandoned one jaw that I was supposed to do. That I honestly was thinking to myself, as this guy was bleeding and bleeding and bleeding despite everything I was doing, am I going to have to take him to A&E? If this doesn't slow down soon, I'm going to have to take him to A&E. I have a bit of experience behind me, and this was a really, really nerve-wracking case, just trying to get him to stop bleeding. And I worry about newbies starting out thinking, I'll do it all guided because then I don't have to stitch. And wanting to do big cases where they aren't quite ready for. I love, like you, I'm a huge fan of guided surgery. But again, something else I lecture on is all the mistakes that I have made with guided surgery, and how it's not always the answer, how it reduces your vision, how it reduces your tactile feedback when doing guided. And therefore you have to assume that it is trying to throw you off, and you've got to check and check and check at every stage to make sure that you've got plan Bs and plan Cs.
So speaking about that, there are a lot of companies out there where they will turn around and say, oh yeah, guided is your answer to everything. In fact, I think there was one company turning around and targeting people wanting to get into implants, saying, well, you don't need to have surgical skills, because send us the STL and the DICOM files, and what we'll do is we'll make a guide for you, tissue punch, drill sequence, place the implant, you're done. It's nice and easy, straightforward. About a couple of months ago, I did a guided dual arch case, and the guide sat nicely, but the bone was so soft that the pins wouldn't anchor into the bone.
Right.
So I then had a fully guided case with a fully stacked guide, so the teeth just needed a quick pickup.
Yeah.
The guide wouldn't see. What do you do? And you know when I found out that the guide wouldn't behave, Bill, was once I'd taken all the teeth out for the patients. Yep. Okay, so what do you do at that point? So I, chairside, had to jerry-rig something to help me stabilize the guide so that I could place the implants and still do the pickup. And it was a very stressful day, Yeah. I remember getting to the end of that day, and I was like, I don't know if I want to do implants anymore. I might get retrained to do ortho instead. Yeah. It was one of those days. So the question really becomes it's not what happens if things go absolutely smoothly, is what happens when shit hits the fan. And this is something that I say to a couple of my mentees who are really starting to excel now, is they see things happen. And to start with, obviously I make sure the patient's safe, but I'm observing them because I'm watching them think, and I want to see if they can problem solve as they're going along. And they get to the end, and if they haven't problem solved, fine, I'll step in and I'll help them through the case. And towards the end, I'll turn around and say to them, what were you thinking when that happens? Because I want to understand their thought process. And I keep saying to them, I said, look, the more complex surgery you start to undertake, the more likely it is something's not going to go quite as smoothly as what you expected. I said, then surgery just becomes a process of problem solving and executing until you get to the final desired result. And you can't do that unless you've either had your fingers burnt a few times or you've had somebody experienced come in and show you through the process.
And that second option is so much easier. You won't end up with grey hair like mine if you have someone
I've got
there who can help.
And I think...
So let's talk about mentoring then.
Yeah.
Because again, it's really difficult to organize. I'm mentoring a wonderful girl at the moment. I have people asking for mentoring all the while. And it's either very expensive for the mentee if they're paying. Mm-hmm. If you've got someone like me who kind of I'm not semi-retired, but I can choose to take a long time over a case that's being done by a mentee without having to just churn through numbers. Yeah. And it takes a lot of organization. It takes a lot of time. It costs both people a decent amount of money. I can put 3 implants in an hour, and I have to book 2 hours for the surgery, half an hour pre-brief and half an hour debrief afterwards. So that's 3 hours instead of 1 hour. That if I'm looking at an hourly rate, even though I'm taking the money for the implants being placed, because they're being placed in my chair, that's taken 3 hours instead of 1 hour. Mm. And I take that on the chin because the mentor is lovely and I want to help, and I'm at the stage where I want to give a bit back. But not everybody is there. You were talking about your practice that was struggling financially. Yeah. You couldn't have afforded to be that I don't know, carefree about the costs, taking that amount of time with a mentee. And so it's not always possible. And I think it's really a bit of a struggle for mentors and mentees to get together in a relationship that works. I'm sure that it is a lot easier for people like me at the far end of their career to do it than someone who's really trying to push and drive and post on Instagram every hour. It's hard.
Yeah.
And I have no answers for how to do that. For mentees, I would say just contact as many people near you who you admire and think might be able to help you, and be persistent, be generous, be nice, be helpful, and hopefully you'll find someone who'll give you some of their time.
There is no magic bullet, right?
No,
as you said, so many factors which come into play. It's how busy the mentors are, how busy the mentees are, what cash flow the mentees got, how much the mentor's charging. There's so many factors which actually start to come into play. And then there's the element of, is the mentor going to do the traveling, or is the mentee going to do the traveling and bring the patient with them, which adds in another level of patients turning around and saying, oh, I can't be bothered to go that far. And this is where it starts to become really quite difficult. I think
then Pav, just to interrupt, then you've got the stress of the mentor going to a practice where he has no idea what equipment they've got. Have they got just 2 implants of different lengths? Do they have any stitches? Have they only got 2.0 silk? I mean, it's really stressful.
Yeah. And you know what, Bill? and quite a number of years ago, I unfortunately did that to Guy McClellan. So he was coming out. He was coming out to do a dual arch with me, and this was very, very many years ago because the patient needed a zygo. So he put the zygos in, and we came to doing the anterior implants and the lower arch. And this was back in the time when everybody was turning around and saying, "Ooh, less titanium, more bone, more soft tissue." So all I had for him was to do the lower arch was 4 implants, and they were 3.25 millimeter diameter and about 11 millimeters length. And Guy was like, "Is this all you've got?" And I was like, "Yeah, it's all we got." And I was like, "Crack on, Guy." And he didn't he didn't say to me anything or at the time. I obviously understand moving forward after that. But it just reflects back on what you were saying, is that, sometimes, we need certain things and it's not set up right. So then there's even more work to do in the preparatory stage beforehand in order to get things running smoothly on the day. And what I was alluding to earlier as well, Bill, is what's worked for me is just staying dedicated to the process. And even when the hurdles come up, that it's an element of, okay, this hurdle's come up, we'll deal with it. And sometimes these hurdles are, I haven't got enough clinical exposure, or it's, oh shit, this has gone wrong with a patient and the patient's unhappy and the letters go backwards and forwards. You can end up in court. There's all sorts of stuff which has happened over the years. And I'm sure it will happen again because we are just human. We're not infallible. And again, if I had people over my shoulder at certain points, my career probably would have been much smoother. And I think this is what you and I are both trying to allude to, is there's an element of keeping patients safe, and there's an element of accelerating the career of budding implant surgeons, wherever they are in their career, but do it in a fashion which is more structured than what we are currently used to. Because people are going and they're placing a handful of implants, and that's kind of like it. They're off. They're on the way. Even my own delegates, when I teach them, I turn around and say to them that, look, you need to start on the simplest of simplest things. And if I was given an option today of, Pav, you know what, you've got a quad zygo in the upper and a subperiosteal frame in the lower. It's either that, or you've got 6 upper first molars where you've got 12 millimeters to the sinus.
Yeah.
Give me the 6 molars every single day. There comes a point where it's just like, as you said, Bill, there's nothing more left to prove. And I just want the easy life now. Don't get me wrong, I'll do the other stuff if I need to do it. But I still have cases where, I've had a couple of recently where people turn around and said to me, Pav, we think this patient needs a zygo. Can you look at it? And I've looked at it and I've gone, you know what? The zygos are too thin for me. I'm not at that stage where I'm going to start doing this level stuff. And I've recommended for them to get somebody like Guy or Risen in to do it.
Yeah.
And it's understanding that, as much as I'd like to do a case like that to push my skill set even further, there has to be a cutoff point where it just turn around and say, it's not worth the headache. And the most lucrative part of implants is actually the patient who comes in, they need 2 or 3 singles. Yeah. From a business point of view, per hour, that's more profitable than a full arch.
So, yeah, absolutely. So I've after having harmed one particular patient, I spent £25,000 going to Budapest and spending about 15 days with Istvan Urban. And I realized how much I would learn just by being his nurse for a month or 6 months. Now financially that's impossible, but just watching how he handles things, how he makes decisions, how he does stuff, that kind of those hints and tips you can't pick up from a video, you can't pick up from a book. It's the skill of someone who's just done it day in, day out for years and years. Having spent all that money for big scary grass, I recommend they see other people. And again, I do full arches very, very regularly, full arches and full mouths all the while. And if I get someone where there's really no bone, I send them off to Evo Dental, because they'll do a really good job, and they can do the nasalis and the zygomas and the pterygoids and get them fixed without having to do big grafts, which is the only option that I have for them.
Yeah.
I have no problems in referring to people who are better at what they do than I am. No problems at all.
Sometimes that peaceful life is worth way more than a potential complication. It doesn't matter how complicated.
We also, I'm hugely lucky in that I've got a whole load of clinicians that I work with who are all brilliant at what they do, but we're all slightly skilled in different things. And so we all cross-refer to each other. Oh, you're better at that. Go and do that. And I'll do this side of that one. And, it just makes life so much easier.
Yeah, absolutely. So, we've spent quite a while talking about the problem, Bill. So what do you think the solution is? Because obviously we've said that there's an element of problem of fees, time, and that the fact that we're not in a salaried position in a hospital where you've got consultants and you can do as much as you want and it's not going to impact your business. Yep. So what would be a potential sensible option, sensible solution?
So particularly for people starting out, I think you need to have a mandated compulsory number of implants that you place mentored. Just like you would do if you were doing any procedure in hospital. The whole thing of see one, do one, teach one, that's out the window. It's not done anymore. It's not safe. It never was safe. It's, learn it, do it with someone there guiding you, and then go off on your own. Now, that doesn't mean you go off on your own and you never need to do any mentoring again or any courses again. Of course you do. Just like when you learnt zygomas, you had someone there with you for case after case after case to give you help, advice, assistance when needed. I think there needs to be a mandated number. Pick a number, 20, 30 implants, whatever the number is, that have to be done mentored. There will have to be some kind of mentor register, so the mentors will need to be accredited in some way. And I think it's just part of the cost of doing business. Now, again, I really don't want to put barriers up to people starting, but so many people start implants, have an absolute nightmare, and go, I don't want to do this. It's not as easy as I thought it was. When if they had someone helping them choose the right cases and being there when they were doing them, that's the way to make it a nice, comfortable, enjoyable learning experience rather than a terrifying seat of the pants horror show.
Yeah, I like that, Bill. I think in addition to that as well, and I know that you're a big fan of this, is documenting every single case, like what you're doing, and then you can actually track your success rates, your failure rates, where things have gone wrong, what has gone wrong. Has it been a surgical problem? Is it a restorative failure? Have you a screw fractured? Is it something that you missed in the occlusion? The more that we track, the better that we can actually end up being as well.
But so few people have any kind of logbook of their implants.
Yeah.
So in our centres, we have a number of surgeons, and so because of that, we have to measure our the one thing that we're really keen on is early implant failures. So if an implant fails within a year of it being placed, we put that down to something the surgeon did, right? And we are all really open. It's in our clinical meetings, it's printed out for everybody. And so we can see our failure rates. And when there is an outlier, we look to see why that is and what we might be able to do to help improve that. And it helps all of us. It's really helped my failure rates. But it's something that's most people have no idea how many implants they place, let alone how many fail. They just have no idea.
I think the other thing that would potentially help as well, a couple of things, Bill, is firstly, as I was alluding to earlier, small study groups. If you're meeting up once every 3 months, you can do it over dinner, right?
Supportive, helpful, encouraging, friendly.
Yeah.
Not study groups of look how big my dangly bits are, but ones that are, I had this problem. What do you think would be a better way of doing it next time? Those kinds of study groups. Which you've got to take the egos out.
Absolutely, which leads me on to the next point that I was getting onto as well, is normalize normalcy. Because what's happening at the moment is on the University of Facebook, on the University of Instagram, everybody's showing these fantastic cases. Yep. They are not showing their failures. And Bill, this is one of the reasons why I have a lot of respect for yourself. I've known you for a number of years now, is you've always said, look, I made a mistake. This is what happened. This is a failure that I've had. This is a failure that I've had. And very few people actually do that. Most people just turn around and say, look at this amazing success I've got. Look at this amazing result that I've got. And it is something. And again, I was speaking to Peter Fairburn about this about a week or two ago as well. And something that Peter was saying as well, he said that, like yourself, he was saying that, you know what, the medics are on another level completely. Yes. Their level of training is far exceeds what we do. Yes. What we do is market driven. What they do is evidence driven. And they said we need to be more like them and take on that level of responsibility for our own professional development and for patient safety as well.
When comparing it with hospital surgical fields, I am astonished that so much of what we do actually does work.
Yeah.
Because, blimey, my training compared with hospital specialties is minuscule.
Yeah.
Anyway.
I think
you've given me a good idea. You've given me a good idea. Get a curry club of local implant dentists to chat.
Yeah.
Just to chat. That's a really good idea.
Cool. We should do that. I'm always up for curry club. So
good.
So unfortunately, we don't have a solid answer for you because it's not one of those episodes. But what we are trying to express is that we need to hold ourselves to a higher standard. And we need to do that for our own safety from a medico-legal perspective, but also is, we all want the best for our patients. And for that, we do need the correct training and the correct mentoring. And I understand that there are limitations. And as Bill said, we're not trying to add more limitations. We're not being protectionist or anything like that. Bill and I are just saying this from a point of view is that we've had our fingers burnt so many times. And a lot of it could have probably been avoidable. And we want to save you, the listeners, from that heartache. And it's, with all the things that I do with my implants, Bill, I decarbonize implants. I still get failures. I'm aiming for, I am gunning for a 0% failure rate, as unrealistic as it is, but that just pushes me to keep studying. I still make mistakes. So after I spoke to Nick Fahy on the podcast a few months ago, most of my work is guided now. Because Nick said to me, he said it's not the majority where you're looking at it going, look how fantastic I am. I did this freehand. It's those handful where you get to the end, it's just like, what the hell happened here? And the question then becomes is that fair to the patients? And the answer is no. And again, I am now in a privileged point in my career where I can actually turn around and say I'm charging more for my implants, but I'm going to go guided.
I had a newbie contact me, and he said, "I've seen that you've posted a case where you took a pilot hole X-ray. Should you still take pilot hole X-rays even if you're experienced, or not?" And I went, absolutely. I wherever it is technically possible for me to do so, I will take a pilot hole X-ray, because you'll be amazed at where you think you're drilling and where you actually are drilling. And this newbie said, "Oh, I'm so pleased you said that, because when I was at this course, the instructors said that, no, you only do that when you start and you pretty quickly discard that." And I was gobsmacked.
What can we do?
Yeah.
What can we do? So, right. So thank you very much for everybody listening in. I'm sorry it's not been it's been more philosophical as opposed to.
I like those talks.
This crazy new technique I'm trying now, because I like trying this. But it's an important discussion to have.
Yeah.
And even if it's you take Bill's idea of making a curry club, and you're meeting up once every 3 months. And what we all want to do is we don't want to discuss the cases which have gone right. We all want to discuss our failures. And I think the most learning comes from the failures. So, Bill, thank you very much for joining me today. I'm sure this won't be the last time that we've got you on the podcast as well. I always appreciate you joining, because we always have a fantastic discussion. So, folks, thank you very much for tuning in. We're Monday night tonight, aren't we? Yeah. So, surprisingly, I've got another recording with Martin Wanandea tomorrow evening. So it's one of those things I keep saying I'm going to try to record as many as I possibly can. And then I had a lull of several months, and people are like, "Pav, what are you recording when you're recording?" I was like, I need to do it. So I'm putting in more of an effort now. So thank you very much.
I'm going on Martin's course next month, the EP01 course. I'm really looking forward to it. He's great.
Yeah. I'm considering doing his course as well, because his results are just absolutely beautiful. Yeah. So the learning never stops, never. So Bill, thank you so much. Thanks.